Let's talk about cerebral palsy. It is not pronounced cerebral palsy. It is pronounced cerebral palsy. We will watch a video that will also address that cerebral point right there. It's a very diverse disorder. One person with cerebral palsy is not going to look like the next person with cerebral palsy. All that it means is that in that prenatal or perinatal period, there was some kind of exposure or lack of oxygenation, something nerve damaging occurred in that very, very early period that reduced the oxygen supply to the brain. And it can cause any manner of thing to happen. It could cause hemiplegias, paraplegias. It could be just the arms. It could be just the legs. It could be just one side. So everybody's neurologic signs and symptoms are going to be very different. It could be ataxia, so motor or gait issues, dyskinesia, spasticity. There can be contractures. There can be tetanic contractions, any manner of things, or a combination thereof. So I'm going to pause the recording to go watch a video. It's called something like, the video we watched was Zach Anner's top 10 things I wish people knew about cerebral palsy. One of them was cerebral palsy doesn't mean there's something wrong with your legs. This is the way he phrased it. Legs are fine, brain is bad, is how he phrased it. So it's not that that part of your body is affected, it's that your innervation was impacted by that event and it was never recovered. So treatment's going to be very variable because the experience is going to be highly variable. And another one of those top 10 things was that CP is as diverse as humanity itself, because oxygenation problems have nothing to do with race, ethnicity, location at all. Okay, hydrocephalus means that there's some kind of abnormal accumulation of CSF in the ventricular circulation. Now again, this just goes back to the anatomy of how that circulates. We have the lateral ventricles, the interventricular foramen, the third ventricle, the cerebral aqueduct, the fourth ventricle, the lateral and median apertures. We have the central canal of the spinal cord, but those apertures go to the subarachnoid space and they get reabsorbed by what? What allows for reabsorption of CSF back into the cardiovascular system? It was a worksheet. Yeah. Well, what's the structure along these things that allows for reabsorption of CSF? These little red dots right here. They're not really red in real life, just for reference. Not aquaporins. I like the way you're thinking, whoever said aquaporins first, but no. Nicely done, arachnoid granulations. Arachnoid villi or arachnoid granulations. So these little things, they're a little bit like blood vessels. They stick up into the dural venous sinuses and they allow for reabsorption of fluid. So hydrocephalus could happen because of a physical obstruction anywhere along that circulation. It could also happen because of a failure of reabsorption of the arachnoid granulations. The arachnoid granulations can stop reabsorbing for some reason. So that's going to be another space-occupying lesion. That's going to increase intracranial pressure and decrease level of consciousness. And we're going to need to address whatever underlying problem is causing the hydrocephalus. It could also be embryological. So remember, you've got your neural crest cells, you've got the neural tube development. That neural tube has to close off at the cranial and caudal ends and at the right time and in the right places. It is possible for that neural tube to not close at the correct location, have an additional closing compared to what it should have. And that tube, the inside of that tube, that's your ventricles at the end of the day. That expands into your ventricular spaces.
Is that one of the reasons why you have to take folic acid? Because neural tube deficit is what happens. So
folic acid, yeah. So maybe hydrocephalus for neural tube development. We're talking more about spina bifida, microcephaly, and anencephaly, which is coming up. So yes, it's related to neural tube development, which is related to folic acid intake. And that's why we put folic acid in all our breakfast cereal, so that we could have less spina bifida. Rather disturbing imaging coming up. The issue here is that this is an infant, her fontanelles have not closed. Because the fontanelles have not closed, there's a lot of space for that cerebrospinal fluid to go into. And that's why she looks that bad, yes. I do not know her age. Okay.
And there's no way to just like, this might be the question, just like drain it?
You can drain it. In fact, that's what this is.
Like,
So this is an adult with hydrocephalus, and we've placed a shunt from his ventricular system proximal to wherever that blockage is, and we're just shunting into the peritoneal cavity where you've got all of the capillary beds of all those mesenteries, and you can reabsorb that fluid through those mesenteries. Boom. Yeah. Yes. This is a space-occupying thing. This will change level of consciousness. Yep. So all of that LOC stuff that we learned before, that's going to apply to hydrocephalus. Depending on time of onset, that change in LOC is going to be different. One thing that can cause a blockage, we've already seen a couple of things that can cause blockages. We talked about pus forming, exudate forming infections in the brain that could get into the ventricles and cause a physical obstruction. Another super fun one is tapeworms. When they go up to your brain and lay eggs in your brain, and your immune system then calcifies that egg, and then that egg pops out and blocks your cerebral aqueduct, and then you have hydrocephalus because of that. Do you want to see a picture? Do you want to see a picture of tapeworms in the brain? It's gonna get upsetting now. So there's a word for this, but let's just go for tapeworm eggs brain, and then I'll remember what the term is for it.
Oh, it looks like.
Yeah. So this is a pretty extreme infection. In the first world, you're probably not going to see this. With some of these tapeworm infections, it's third world, it's people eating raw pork for fun. Yeah, there was actually a specific case that I'm referring to, tapeworm eggs, legs, where this woman, it's on x-ray. Here she is. She ate a lot of raw pork. Oh no, it's a Chinese, no, why does this say Chinese man? That's not a man. Oh well, they ate a lot of raw pork. It's just, yeah. So don't eat raw pork. Generally, American pork is considered safe because of the curing process, because of our farming practices. Not raw, but we're actually revisiting our recommendations for cooking temperature for pork, and it may be safe to eat rare. Not that I'm going to ever, but it's actually, or like sous vide style. You could probably cook it sous vide and it'd be safe. But the current recommendation, I want to say like 165 or something like that. That might actually be higher than necessary for American pork. I agree. I learned that the other day and I was like, don't care. Yeah. Don't eat uncured ham. Don't eat it. Okay, let's keep moving on. We've got a lot of slides. So we'll move on to our good friend MS. Some more issues. So MS, spina bifida, ALS, spinal cord injury, Guillain-Barré, which I think we've seen before and we will see again, and Bell's palsy. So MS generally is considered an autoimmune condition, which means polygenic and multifactorial. We have not identified all of the environmental factors. If you want to run through some conspiracy theories with me on that later, I will, but I'm not going to put it on the recording. So what's happening with MS, it's actually demyelination of the central nervous system. We think of it in terms of our peripheral symptoms, but the primary pathophysiology is happening in the CNS. And what's happening is demyelination. Our immune system is attacking the myelin sheath. That initially just causes demyelination, which is going to cause its own problems, but ultimately we're looking at axon destruction. as a result of that demyelination. So when we say multiple sclerosis, we mean that there will be multiple sclerotic lesions. We will look at an MRI or a CT and we will see these sort of bright spots that mean that cell death has occurred. And again, the symptoms are going to be related to where are those lesions. That's always the truth with our brain stuff. So it often impacts things like the optic and oculomotor nerves and certain spinal nerve tracts, even though those are peripheral nervous system, and we're defining this by the central nervous system. Some of our peripheral signs and symptoms are related actually to a different aspect of MS. It's an inflammatory pathway that's poorly understood that leads to some, but not all, of the peripheral symptoms. Because this is autoimmune, anything that increases inflammation is going to exacerbate the progression of multiple sclerosis. Heat, infection, trauma, stress will increase your inflammatory response, which means your body is going to go through a round of destroying myelin every time you have that. You get a cold, you get the flu, your MS symptoms get worse, and it tends to go through cycles of exacerbation and remission, with each exacerbation progressing the disease a little bit more. So again, if this is an adult, and it's usually an adult we're talking about, that brain damage can be, once this has occurred, that's permanent, right? Demyelination we can recover from to a degree, like we have with Guillain-Barré, right? But once a neuron is dead, a neuron is dead, and it's not coming back. So that's why it tends to be progressive. So we can modulate the immune system, we can modulate the inflammation reaction, but we can't get rid of the disease.
Is this genetic, or is it not always?
Again, with autoimmune, there's a genetic component. There's probably some kind of environmental trigger. Yeah. And again, it's poorly understood. The old textbook had this categorized as one of the 4 hypersensitivities, but I entirely disagreed with the hypersensitivity it had it categorized as. And I would be mad at my students if they put that on their worksheet for that hypersensitivity. But the new updated version doesn't put it there. So somebody else got mad about it aside from me. I wasn't the only one. Okie dokie. So again, there's no cure. We can look at MRIs to see the multiple sclerotic lesions. We can look at their antibody profile and see if they're developing antibodies against your own oligodendrocytes. That's about it for MS. It's a complicated disease. We could probably spend an entire hour on it, but we're not going to. Any questions about it? Okay. So we actually already addressed this, where there's this development of our neural tube during our embryological development. And the neural tube has to close cranially and caudally at the right times and in the right places. The spina bifida is going to be failure of neural tube closure caudally, in the caudal region of an embryo. And it's by degrees. It's not you have spina bifida or you don't. There's a whole continuum of conditions that we can refer to as spina bifida. So there's actually a really, really subtle form of it called spina bifida occulta. And in this form, that neural tube also contributes to the vertebral column. And in this form of spina bifida, that posterior arch, the dorsal arch of the vertebral column in the lumbar region, is underdeveloped. So you may not have a posterior arch or a spinous process of some of your lumbar vertebrae. This person may not even know that they have spina bifida. There may not be signs or symptoms. There may be like a slightly squishy spot. It actually tends to grow some dark hair right here. So somebody with otherwise no body hair, but a patch of dark hair on their low back may have spina bifida occulta. Yeah. It's not the dimple. Nope, nope. Then we get a little bit more serious. We have the failure of the neural tube development that leads to a meningocele, and that's going to be cerebrospinal fluid herniating out into a bulging sac in that lumbar region. But at this stage, the spinal nerves are not involved. The spinal nerves are not herniating into the sac. Whereas myelomeningocele, you'll also have the spinal nerves herniating into this sac. And this one is going to be the most severe. It's also going to be correlated with other congenital disorders. So what we're going to see, for example, is clubfoot and imperforate anus with our myelomeningocele. So at that point, you have neurological development. You have a problem with innervation to the legs, lower limbs, pelvic region, and anything else that those nerves may be going to. So that's your most serious spina bifida. The other end of this, if there is a failure of neural tube closure at the cranial end, that would be anencephaly, lack of brain development, or microcephaly, too small brain development. And that's where that Zika virus comes in. It's actually intervening in that folic acid pathway, as we understand it. That's the most recent research I've read. Okay. ALS is a lot like MS, kind of. So amyotrophic lateral sclerosis means we are not feeding the muscles from the lateral portion of the spinal cord. It's a progressive neurodegenerative disease. It's also demyelinating, much like MS. That's why it's like MS. But the demyelination happens in a slightly different order, and it especially tends to impact upper motor neurons. I said that wrong. So this goes back to your idea of the corticospinal tract, which I know you've all forgotten at this point. Tell me about the corticospinal tract. Sensory or motor? Motor. How many neurons in the circuit? I might have heard it, but it was quiet. No, far fewer than 10. Not 3, not 4. 2 neurons, upper motor neuron and lower motor neuron in a corticospinal. Super simple. Where is that upper motor neuron cell body located? It is in the brain. Where in the brain? Out of the pons. Primary motor neuron cell body, initiating motor movement. No, and in fact, this one completely bypasses the thalamus, unlike the sensory pathways. Frontal, what part of the frontal lobe? We said it earlier for one of our motor regions. In fact, Phil got it earlier. Say it loud. What part of the frontal cortex? Precentral gyrus. Boom. Well done. And I know that was Phil because he's dancing, even though somebody else said it out loud. Rachel said it. Okay, so primary motor cortex, precentral gyrus of the frontal lobe, houses the cell bodies of the upper motor neurons, which then go through the brain, cross at the medullary pyramids, then they go down the lateral portion of the spinal cord, which is where we're getting the lateral in this ALS. And then it goes to the secondary, the lower motor neurons. Where are those cell bodies located? I got one choice left. If it's not dorsal, it's not medial. Ventral. Well done. Okay, so those lower motor neurons are in the ventral gray horn of the spinal cord. So you have an upper motor neuron, and that's going to innervate the lower motor neuron, and that lower motor neuron is going to go out to a skeletal muscle and innervate it. That is your corticospinal tract. Is it going to be ipsilateral, contralateral most of the time? Which one? Ipsilateral or contralateral? Contralateral. Rule of thumb, it always is. Yeah. Awesome. Yes. Okie dokie. So fun fact about lower motor neurons, or upper motor neurons rather, some upper motor neurons are excitatory, some upper motor neurons are inhibitory. So if somebody's had an initial insult to an upper motor neuron, you might actually have hyperreflexia for a little while, for like the first 6 months, and then things wear away, and then you have absence of reflexes. And that's why that anatomy was important. Yeah. Upper. Yep. So the ALS is more mainly impacting the upper motor neurons, although it's not really going to be illustrated that way by your textbook. I happen to know it's true. So weakness, atrophy, cramp, stiffness, irregular twitching of muscles, hyperreflexia, followed by areflexia. The thing with this one is there's no cure for it, first of all. Most people are going to die within 3 to 5 years of diagnosis. It's very, very fast onset. The issue is when our death of neurons happens to neurons responsible for reflexes like swallowing. Like breathing problems develop very quickly. So swallowing is a lot more important than you think, right? Swallowing is keeping you alive every day. If you don't swallow reflexively when saliva is in the back of your throat, you're going to choke to death very quickly. Yeah, all of your patients who had MS, ALS. So ended up dying of pneumonia. That makes sense. That tracks. So yeah, that's ALS. Spinal cord injury, a problem of the young. This is the hold my beer problem, which makes males 3 to 4 times more likely to develop spinal cord injuries than females. So many more males, yeah. So don't tell people to hold your beer and then, jump off the roof into a small kiddie pool. That's a bad plan. Don't do it. So usually traumatic. Motor vehicle accidents going to be a really common cause. Falls, penetrating wounds, especially gunshots here in America. Sports injuries can also be. So this cord could be compressed. It can be transected. It can be contused. So contusion being a bruise, right? Impact from the outside as opposed to. There could also be hyperflexion or hyperextension of that spinal cord. And again, there can be a secondary injury. This is still CNS. Spinal cord is still CNS. And so we can have that same pathway of the primary insult and the secondary physiological response that does just as much, if not more, damage. So with our spinal cord injury, unfortunately, a lot of the time we're not going to know right away how bad it is, right? There's going to be inflammation immediately after an accident, and somebody may be permanently paralyzed, they may be temporarily paralyzed. We're not going to know until that inflammation is gone, whether it's temporary or permanent. One thing that can happen long term is something called autonomic dysreflexia. So I actually have to get out of this mode so that I can expand the size of this. I didn't want to add another slide. I probably should have just put this on a second slide, but here we are. So autonomic dysreflexia is when somebody's had a spinal cord injury in the past, and now they have some kind of problem going on distal to the site of that injury. So they should be receiving sensory information from, let's say, their shin. They should have motor innervation going to their shin, but they have lost it due to a previous spinal cord injury. Now, there's still spinal cord reflexes distal to that site. Some of those reflexes still work. So the way you should think of autonomic dysreflexia is the body is trying to tell the brain something is wrong. And that thing that's wrong could be any manner of thing. Maybe they just have to use the bathroom. Urination or defecation, having a full bladder or bowel can cause autonomic dysreflexia. Another thing that can cause autonomic dysreflexia is going to be busting your shin on a coffee table and not being aware of it. So it could be anything from very, very minor things that are going wrong to very, very major things that are going wrong. Yes?
It happens a lot with when you do a program with a spinal cord injury, because their body can feel what you're doing and it doesn't like it, and it would drop your blood pressure, it would drop all this stuff, and you'd have to wait because they don't realize what's happening,
right,
but their body does.
Exactly. So what you're seeing with it is those changes to your blood pressure, those changes to, that's not really legible, is it? Changes to temperature, blood pressure, sweating, pounding headache, a flush, tight chest, stuffy nose, blurry vision. So you're seeing constriction of blood vessels causing that change to blood pressure. So somebody who's had a previous spinal cord injury, hopefully they're aware of this, this can be a medical emergency and need to be addressed. Maybe they'll toilet first to make sure that it's not urination or defecation that's the problem. After that, we've got to check out exactly what's going on. If there's an injury, we need to address it. We also have to immediately address the blood pressure changes because that's going to initiate cerebrovascular events. Right, so once you've had one injury, you're much more likely to develop another one. That tracks. Yep.
There was a lot of like kids like jumping off or even thinking there was a landing under there, and there wasn't, or and a lot of suicide attempts too.
Yeah. Okay, so when somebody has injured their spinal cord, we try to stabilize the spinal vertebrae. As I understand it, we are changing our rules about backboarding in EMS because a lot of people were being backboarded unnecessarily and developing pressure ulcers, being kept on that backboard for a very long period of time. Again, I don't know what your new protocols are, so ignore my take on it. There's always the chance that they'll develop neurogenic shock, and you already know about neurogenic shock. That's when you get a conk on your head and you dysregulate all of your blood vessels, and then that widespread vasodilation causes fluid shift. That means blood doesn't get there. So whatever the outcome of that spinal cord injury, it's going to depend very much on what it's doing, how you treat it. We've seen Guillain-Barré before. We'll see Guillain-Barré again. Do you remember what the most dangerous aspect of Guillain-Barré was? We saw it in a different system, the system where it can kill you if it reaches it. Respiration. If it reaches the respiratory diaphragm, that's when it's more likely to kill you. So what happened was you got sick. Maybe you had some bacterial infection of your GI tract a few weeks ago. And now you're having an inflammatory response to your own peripheral myelin. And it does occur in the periphery, right? It's going to happen in an ascending pattern from the feet up towards the lungs. Let me get my thing on again. From the feet up towards the lungs, an ascending pattern. There can be complete spontaneous recovery from this. You might recover from it spontaneously. Or maybe we gave you plasmapheresis to try to get those antibodies out of your body. Those antibodies were attacking and targeting your myelin sheath for destruction. What's that? So like an autoimmune response, definitely call it a hypersensitivity, but it's a response to inflammation. So like inflammation first, and then you started targeting your own myelin with your own immune system. I know, it's a good one. Of course it's going to be there. It's going to be there eventually. Just which exams it's going to be on. So Guillain-Barré, progressive, ascending, paralysis, respiratory muscles. And again, 85% of the time, this person's going to completely recover from it. 15% are going to have some lasting problem with their innervation, maybe a paresthesia. Or maybe not. And that's about it. Let's see, Bell's palsy. That's going to be specific neuropathy of the facial nerve. Sometimes idiopathic. There can be a viral form of Bell's palsy. I've seen it, or not specifically, but I've heard of it being due to impingement of part of the pathway of the facial nerve as well. So a lot of different things can cause Bell's palsy. I don't know if we necessarily want to call it idiopathic. I think we have identified a viral pathway for it. See. So because that is your facial nerve, that's two zebras bit my cousin right there. You guys remember two zebras bit my cousin for the facial nerve topography? So temporal, zygomatic, buccal, mandibular, cervical. Two zebras bit my cousin. So it's innervating the muscles of facial expression. Motor 2 muscles of facial expression. That's not all 7 does. 7 also does taste. Special sensory for taste. So somebody with Bell's palsy, aside from having usually unilateral paresthesia am I using the right word? Paralysis of muscles of one side of the face, they may also be lacking sensory information from the tongue, so things are going to taste very weird. like very metallic flavors suddenly, because all they're getting is the sense of smell, maybe taste on the opposite side, right? It's not going to taste right.
So for this closest stage, say it's a virus or it's idiopathic?
I would go with viral etiology most of the time. Again, there are like inflammatory or compressive ways that you could also express Bell's palsy, which is probably why they put idiopathic on there. Oh my gosh, we've only got about 6 minutes until I need to dismiss you for lunch. How about we review some anatomy for the ear, but then I stop there. Does that sound good to everyone? Yep. Okay. All right. What is the boundary for the external ear? Where do we transition from external ear to middle ear? The eardrum, which is known as the tympanic membrane. And then what are our boundaries for our middle ear? What's in our middle ear? The ossicles, the malleus, incus, and stapes. Stapes. That's the one. Yep. You also have your eustachian tube, also known as your pharyngotympanic tube, also known as your auditory tube. There's too many names for that tube. Where's that going? What part of your throat? What part of your pharynx? Nasopharynx. Good. And then your inner ear is defined as what structures? Cochlea and semicircular canals. Excellent. So if you had an external ear infection, you'd probably just have some redness. Maybe your eardrum would be a little red. If you had a middle ear infection, you'd have problems with your ossicles. Swimmer's ear can be related to that, yeah. And then if you had an inner ear infection, at that point you're talking neurological involvement. Yeah, it would impact your cranial nerve 8, vestibulocochlear.
Somebody described to me like something is just shifted a little bit. What is shifted in there when you have vertigo?
You have the answer to that already. What is shifted in vertigo? What aspect of fluid? There are.
Because somebody described it to me.
The otoliths.
So it's yes, otoliths. There we go.
Otoliths. So you have an otolithic membrane, and it's got little calcified little rocks in it. I always describe it in AMP2 as like 1950s housewife jello dessert with a bunch of fruit floating in it, right? So you have your otolithic membrane as you tilt your head side to side, and that otolithic membrane shifts physically, right? And then you have these little hair cells sticking up into this jello layer. And when you deform the jello layer, you deform the hair cells, and that sends the neurological signal. That mechanical deformation is transformed into action potentials. Okay, sound familiar? Okay, and that's just your head position. You have something similar with the hair cells sticking up into something gelatinous for rotational movements. You've got your little hula hoop shapes, and you have this crista ampullaris bending over at like the entrance to the hula hoop, right? When the water sloshes over it, it bends it over, and that sends action potentials that I just spun around in my chair, whee, right? That just bent my crista ampullaris in this semicircular canal and informed me that I spun around in my chair. So what can happen is that otolith can pop out of there and shift and go somewhere else. We can otherwise mechanically deform those hair cells and send an errant signal. A signal that should not be there is getting sent that my head position has changed, my rotational momentum has changed, something has changed, except you just got the neurological signal for that without the accompanying physical movement. It's a different piece of information coming from your vestibule versus your eyes versus your proprioception. Yeah, they usually do.
You have like a stand and this like little ball and it just falls off, and then you can put that ball right back up, and I was like, okay. And it was a doctor. And he made it sound like a little ball on a pedestal, and we just put it right back. Yeah, literally, how a doctor explained it to me.
That sounds terrible. Cerebral. Okay, now if you take your cochlea, and it's in a little snail shell arrangement, right? But if you could magically unfurl it, which you physically can't, but let's pretend just to visualize. If you could unfurl it, it would look like this. And you've got your oval window up here, your round window down here. Where are high-pitched sounds going to register in this structure? At the beginning. Do you guys remember how I did that in AP2? Do you want me to make the sound? Okay. It's more of a piano situation. So again, you've got hair cells all around this. Now it's called a tympanic membrane. Make sure I said that right. Not tympanic. Sorry, not tympanic. Tectorial membrane. I say that reversed half the time, which is why I corrected myself. Tectorial membrane all along this structure right here. And underneath that tectorial membrane are, again, hair cells. So different locations will be sensitive to different frequencies of vibration, high frequencies, high pitch, low frequencies, low pitch. So early here, this part of the membrane is sensitive to high frequency vibrations. That vibration compresses that tectorial membrane, deforms the hair cell. You get the ee versus down here, the lower frequency vibration deforms the tectorial membrane, and then you get the ee, and so on and so forth.
And then so when we lose high frequencies first, that's the first part that like stops working.
Absolutely. Yeah. And that's why we're reviewing what we're reviewing. Is we're just gonna, knowing the anatomy, we're just gonna be like, and that was this, and that was this, and that was this. And that's what we're gonna do when we come back from lunch. So there's our tectorial membrane, which I spoke incorrectly before. There's the hair cells, and those are gonna go directly to the cochlear division of vestibulocochlear. And again, this one was the vestibular division, coming from the vestibule and the semicircular canals. Ringing a bell? Yeah, this was all part of your prep work, but I had a weird amount of time to fill. So I'm going to go ahead and pause now and release you for lunch.